Okay, hello everyone. My name is Joe Sarmelli. I oversee Grand Rounds here. We've got a new experience today of trying out a small in-person group for today's Grand Rounds. And I'd still like to encourage you to write in any questions or comments about today's presentation. We can go through those at the end. And I'll sit down over here and turn it over to Dr. Pamela Collins.
Thank you so much. Hello, everyone. I'm delighted today to introduce today's Grand Round speaker, Dr. Tatiana Taylor-Salisbury. She's a public mental health scientist who uses human-centered design to help health and community service providers in low-resource settings actively engage young people in the development of scalable and sustainable solutions to positively transform their health, wealth, and relationships. After completing her undergraduate degree in human biology at Stanford, she moved to England to study evidence-based social work at the University of Oxford. She completed her PhD in 2012 in psychiatry, examining the relationships between mental health expenditure, service provision, and quality of care in longer-term psychiatric rehabilitation facilities across Europe. In the same year, she joined the faculty at King's College London, and she remains at the faculty of King's College London, as well as the London School of Hygiene and Tropical Medicine as a lecturer at the time, and a member of the Center for Global Mental Health. She's now the deputy program lead of the Masters in Global Mental Health and co-organizer of one of the program's core modules. She is also the deputy director of the college's WHO Collaborating Center for Research and Training in Mental Health. She will tell us about her research today, so I won't go into that, but you're very welcome, Dr. Salisbury, and I'll turn it over to you.
Great, thanks, Pamela. Hello, everyone. Thanks for having me. Today, I'm going to talk to you about some of the research that I'm conducting as part of a fellowship that I hold, which is funded by the UK government, and it's called the Future Leaders Fellowship. So it's a very snazzy title. And what it does is it allows researchers to think about innovative ways of tackling existing complex problems. And so I'm going to talk to you about that problem today. So I think kind of in discussion here, I found out that many of you already have a nice mental health background, so I don't need to go into this in very much detail. I'm used to presenting to a very wide range of people, so I've got these bits and pieces of information. But I think the key thing here is thinking about resources for mental health globally. So despite the fact that we know that mental health is a big problem and it affects very many people, the national health expenditure in mental health is very low globally overall, with an average of 2%. And that also then trickles down into the availability of mental health professionals. So globally, there are an estimated 1 mental health professional for every 10,000 people. So this causes quite a lot of problems when we're thinking about being able to provide mental health and have access to mental health care, but also around mental health promotion and prevention activities as well. So I work in global mental health, and one of the kind of stark areas for me, I think, which galvanized my kind of desire to work in the field, is these kind of set of figures that 90% of the global population lives in a low or middle income country. However, when we look at the research, actually it's the inverse, in that only 10% of the research is actually conducted in these areas. So we have a huge problem here, especially for mental health, because of all the kind of contextual and cultural issues that relate to mental health issues. If most of that research is being done in high-income countries, then that kind of availability and transfer of interventions to low and middle income countries can pose a problem. And I think we've seen that over the years in the kind of still limited mental health services that are available in many of these countries. So I'm sure you're all aware around the Sustainable Development Goals, and I think that this goal 3 about mental health and well-being really is helping to kind of push the agenda along with COVID, which I think has helped as well to make everybody aware of the effect of environment and other social issues on mental health, to allow us to really think about what it is that we're doing. And I think that what COVID has done as well is to allow us to reevaluate the way in which we provide mental health care, and also if there's other ways, potential other ways in which we can do that to improve access and also appropriateness of services. So this slide I put together to kind of illustrate the traditional way of intervention development. So first you start off with this problem, this very tricky problem that's all in knots and you don't know where to start and you don't know exactly what you're doing, but you begin to untease this kind of ball of tangles. And we do that through looking at existing evidence around the problem, any relevant guidelines or recommendations, theories and frameworks, and also seeking the opinions of experts. And traditionally, these experts are clinicians or researchers, those who have kind of professional knowledge and experience of mental health. And if we're lucky, by continuing to ask questions and trying to unpick and untangle this ball of wool, we might get a handle on it. And so then we get to a solution that works and is successful. However, I think that there's, what we've seen over the many years is that in global mental health in particular, this focus at the beginning, because of the lack of availability of mental health treatments and services, was that there was this big rush to develop and provide and test interventions. And we did that very well, and there are quite a few interventions that have really good evidence. However, when we look around, we don't actually see those interventions in these places, and we just see them confined to our conferences, journal articles, those sorts of things. And so there's something that's not happening. And that for me was kind of the real crux of it. Why is it that we've got, all these interventions that work on paper and work in a trial in a controlled setting, but actually in real life, they don't happen, or they're not as successful as they were within the scientific research. So I think that one of the main reasons why this is the case is because we haven't really been involving those people that are vital to the delivery and the uptake of interventions. We have to think that, people, if we're doing anything with people, it's complex, it's messy, and we have to really think about how we're going to approach that. And it hasn't really worked for us kind of saying on high, we know what's good for you, you need to do this, and this is the only way in which you'll be able to be helped. And so really, we need to have this equitable partnership in talking about this and bring all of our expertise and experience together in order to kind of find the most effective solutions that are scalable and sustainable. Because really the issue is that the problem, if we go back to that analogy of this kind of tangled ball of wool, and also the solution really depends on your perspective. So based on our own experiences, our training, when we look at this ball, there are certain bits that are going to stick out to us, certain colors in this image. And that helps us to figure out what the solutions are. But if we are just focused on what the solution is for us as researchers or clinicians, and then we go and develop we use that solution and try to get other people to provide it or take it up, we are kind of neglecting all of the other priorities and needs from other perspectives. And so it's not surprising if it doesn't align with people's ideas of what they want or what they think their job roles and responsibilities are, that these things don't kind of take off, and instead they are kind of left to wallow. So really I'd like to, and what the research that I'm doing now does is kind of really rethink this whole method of addressing these problems. And by doing that, really opening it up so that when we say expert opinion, it isn't just clinicians and researchers, but actually all of those people that are required to deliver an intervention or make it available. So who's funding it, who's managing it, who's planning it, and then also the gatekeepers and the people who are expected to take on, to actually take up the intervention. So does it speak to them? Is it meeting the needs that they have in their daily lives? And so can we package the things that we know from an evidence base that work to improve mental health outcomes in a way that's actually attractive to people so that they want to take part in these interventions? So that kind of brings me to the Inspire project, which is the project that's part of my fellowship. And it focuses on adolescent perinatal mental health. And here we're working in Mozambique and Kenya. And we know that, adolescence, we know now is, an intensively vulnerable time for mental health problems, and that a good foundation of skills is needed in order to deal with the challenges and the changes that occur during this time. But then if we add on to that, another particularly vulnerable time for people, which is pregnancy. So putting these things together, it's not a surprise that adolescents are particularly vulnerable to mental health problems during pregnancy or the year after birth. And if we look in particular at Mozambique and Kenya, we know that Kenya has the 10th highest absolute number of pregnancies. And in Mozambique, they have the 4th highest rate of adolescent pregnancy on a global scale. Now, despite this, despite kind of the potential impact and the knock-on effects of poor mental health during this time for these young girls, there haven't been any evaluations of interventions in sub-Saharan Africa for this particular population. And some people say, well, that's nice to kind of focus on this, but this is no longer a problem. We are we've been focused for a very long time on reducing teenage pregnancies, and there is a reduction in the proportions of teenage pregnancies, over the years. So is this just a problem that will go away on its own? And the kind of answer to that is that actually, although it's true that the proportions are going down, the absolute numbers actually in Africa are expected to increase because of the demographics of that population. So you have lots of young people. So even a smaller proportion of young girls that do become pregnant can lead to an increase in numbers. So this is really important. And I think it also goes into the way that we think about kind of teenage pregnancy. So because the global effort has been so much about reduction, it's almost as if when girls do become pregnant, and they're becoming pregnant either because it's unexpected or unwanted, but there are some girls that are planning and they are married, and there are other issues at play. It's not necessarily as black and white as we might want or hope, but we kind of have, we wash our hands and say, well, we've done everything that we can to try to convince you and try to get you to not become pregnant. But now you are, so there's nothing we can do. You've kind of messed it all up. And I'm not very happy with that. And I think that there's a lot of things that we can do to support these young girls so that they do continue to have fulfilling lives and they're able to reach the goals that they set for themselves and for their families. So the Inspire project really aims to develop both a scalable and a sustainable way to support adolescents' mental well-being during pregnancy and the year after birth. And it's a kind of large partnership across different organizations. So even within King's College London, we've got myself at the Center for Global Mental Health, but we've also got colleagues from the Center for Implementation Science that are part of this project. We have our colleagues from the Royal College of Art and the Helen Hamlin Center for Design who provide human-centered design expertise. And then we have our implementing partners. So in Mozambique, we're working with the International Center for Reproductive Health. And in Kenya, we're working with the Aga Khan University. And within these countries, we're based in 2 separate areas. So in Kenya, we are based in Kilifi County, which is just outside Mombasa. And in Mozambique, we're working in Tete district, which is in the middle of Mozambique. And in both settings, we are recruiting from both urban and peri-urban settings. So it's a wide group of girls, and also the context between those 2 communities is very different. And that was done purposefully so that we could try to see if we could develop an intervention which potentially had generalizability across multiple settings and contexts. So how are we going to do this? So as I mentioned before, we're using a blended approach to this intervention development, and that's using human-centered design, systems thinking, as well as implementation science. And so in our first stage, we're really partnering with young women. These are adolescent girls, but we're also including young women who are 19 to 24 who were pregnant when they were adolescents, so that we could understand that trajectory and also be able to ask them in hindsight, what were the things that helped them or the things that were barriers, and what would they change or what would they like to see happening for other teenage mothers, including their partners and families. And this is really important because they're the gatekeepers. So they will allow or block these young girls from participating in an intervention. Then we engage those communities. So we're looking for community influencers like traditional healers or religious leaders, teachers, and principals of schools, those adults, and also those peers that have a lot of sway and influence over these young girls that can either help them to increase access to an intervention that we develop, or they could actually be vital in blocking access and the success of the intervention. And then we include the local health authorities as well as other community-based organizations so that we can understand what their needs are, what they're doing, what they feel are their responsibilities to these girls, so that we can try to make sure that where we deliver the interventions and who we decide will be the facilitators of this intervention actually aligns with people's ideas and beliefs, and also who they would generally go to for help or problems of this nature. And so through a mixture of kind of traditional data collection activities like one-to-one interviews and focus group discussions, as well as additional observation techniques, such as photo voice, where we give girls cameras and give them some prompts to take photos in their households as well as in their local communities to better understand their experiences, and then bring them together to really talk about the pictures that they've taken and what are the barriers and the supports that they have for their mental health during pregnancy and also the year after birth. And then doing something called a spiral walk, which is a new technique to me, which is partially around sisters community mapping and trying to understand what are the formal and informal supports that are available. So the researchers meet with a girl either at her home or at the health facility, and from there they walk around in concentric circles. And through this walking and kind of taking pictures, what they're looking for are places where the girls go to and interact with. And we want to know, where are places that they feel supported and cared for and safe? Where are places that they would like to go to, but actually for some reason they feel like they can't? And where are places in the community that they would never go to? And then going into conversation with them about why they have given, why they feel this way about certain places, to help us to understand where might be best to place an intervention for these girls, so it's something that they feel comfortable taking up. So in doing that, then we distill that to identify a priority challenge or challenges, and then ideate with the community and brainstorm ideas for solutions to those challenges. And then as quickly as possible, we really try to create a visual representation through a prototype of what an intervention might look like, so that we can show it to these girls and other stakeholders and ask them their thoughts, because it's really hard if we say, well, what is it that you want? People will just sit there very quietly and not know what to say, because it's very difficult to come up with, an elegant answer of what it is that you want. But it's not so difficult to look at something and say, I like this, or I definitely don't like this. I would never go to that person to talk about this problem, or yeah, I like this, and could you add, this bit to it? So that helps us with this conversation and further refinement of a prototype to develop our kind of first workable solution. And this is something that's done in conjunction and, together with all of those stakeholders, so that they have some buy-in into what it is that we're doing. And here's just some photos so that you can see a previous study, which is our proof of concept study in another area of Mozambique, where we worked the kind of larger picture shows a card sorting activity, where once we got to know what the general challenges that girls were facing, we created these illustrated cards for each of those challenges, and then asked them in groups to come up and rank the challenges in order of kind of what was most salient to them versus kind of the least important, although we kind of prefaced it with the fact that all of these were kind of significant challenges. But if they could figure out what was the most important thing to them, and that was to help us to figure out what our priority challenge was going to be, and to kind of focus everybody's minds on a particular issue in order to come up with a solution. At the top right, you can see some of my colleagues. So those are some of the psychiatrists from Mozambique, as well as members of our design team, really working on a big map of the community so that they could understand where young people were going, and also where the different types of formal and informal supports were. And then lastly, at the bottom is just the way that we started kind of pulling together the various themes and ideas of what were coming up, trying to work out what were the main challenges and how we were going to move forward. So after we've done all this, then it's time to refine. So we move into an adaptive pilot where we deliver the intervention to a small group of women or girls and ask them kind of all sorts of questions after each session about the content, the delivery, and try to figure out what's working and what's not working and how we can strengthen it. And we do that with the girls, as well as whoever is the facilitator or the provider of that intervention. And then we then refine that intervention based on the insights that we get from those groups. And then we either do updated training for the facilitators and then deliver that refined intervention to another group of girls. So we've kind of mapped out time over about 1.5 years to do this up to 3 times, so that we can further kind of just tweak the intervention so that at the end of this process, hopefully, we will have an intervention that has the best chance of being successful. And we know also that it's one that is in alignment with the kind of motivations and behaviors and needs and priorities of those groups that will be key to the success of the intervention. And then lastly, we move into the final testing, which would be a randomized controlled trial. So this fellowship is a 4+3 fellowship, as they call it. So I've got an initial 4 years of funding, which will take us to stage 2. And then if everything goes to plan, there will be another tranche of funding that comes for an additional 3 years. And hopefully we'll have some money to try to conduct a randomized controlled trial and really understand what the impact is on mental health, what the implementation outcomes are, and also looking at wider impacts on adolescent mothers and their communities. So I think here, what's also very important is, in addition to really working with the community about the intervention and the delivery strategies, we are also working with them around the evaluation and determining the outcomes. So we want to know what are the things that different stakeholders need to know to believe in this intervention, and to also champion it with their peers and colleagues. So those things are oftentimes not the same things that clinicians or researchers want to know from a trial. So it's really important for us to kind of ask them what it is that they want to see so that we can tailor that output to them and help them to make a case to others as to why this should be embedded within existing services and systems. So just to kind of go over this a little bit more so that you know what are the types of things that we're collecting and how do we pull together. So this is kind of my attempt at trying to make an illustration of how we're pulling together and blending these different approaches of human-centered design, systems thinking, and implementation science. So we start off with this question about how might we better support adolescent girls during pregnancy and the year after birth. And in that empathize phase, so that's where we're really just getting to know the views and ideas and experiences of different stakeholders. And we're looking at a wide range of issues around, what is going on geographically, what is the epidemiological data around the issues that we're looking at, what are the socioeconomic and sociocultural issues, and then looking at ethical, legal, and political frameworks to really orient ourselves and understand that context. Then through the define stage, we're really pulling things together to look at the system in general and how is the system working, either health system, but also other community systems. What is that structure? What are their relationships with each other? And then where are the barriers to implementing an intervention, but also where are the opportunities? What are things that are already going on or planned to begin in the next few years, which might be really helpful for a starting off point for integration. And then that brings us kind of back to our priority. So once we get our priority challenge and what is it that we're actually focused on, then we begin to expand again in this ideation phase. So we brainstorm these solutions and then we start to refine them. So the idea is just to try to get as many ideas as possible. There's no value judgment or quality judgment about these ideas. And, I think even ideas where you think that's never going to happen because you need so much resource or you need all of these things to just come together in the right way. There's oftentimes something in that idea that we can work with and try to integrate into another idea. So really trying to get those thoughts. And I think the key thing here is that we're not looking for something, I guess people oftentimes think that because it's innovative or all of these things, you're looking for something that is just, you've never seen before. It's new, it's shiny, it's, bizarre. But really, I think the best interventions are the most simple interventions that are easy to actually integrate into existing systems, because anything complex will either get muddled up in its delivery or just won't be delivered at all because it's just too complicated. So as we go through that, then we begin to prototype. So we try to lay down, the ideas about what the intervention is, that underlying implementation theory and the strategies, thinking about the delivery agents, and then what is that process and what are the outcomes of interest for us. And so at the end of that process, and this kind of brings us to the end of the first 4 years, we have this prototype that's ready for testing and further refinement. So that's what we're aiming for right now. At the moment, we're at about the ideate phase. And towards the end of May, early June, we're hoping to kind of be at the end of that double diamond where we've got this prototype that we can begin to flesh out and then test in early 2023. I think that's it for me. I wanted to make sure that we had enough time for discussion because I think that's the most exciting part. So I've put up some contact details. If anybody has any questions or wants to get in touch, please do. Also, as part of the fellowship, a kind of ethos of how we're working as a collaborative team within Inspire, we've created this design and mental health website, which we're hoping provides kind of lay language introduction to these types of techniques, talks about the projects that we're working on, and also is a place where we can gather feedback and information from others to inform what it is that we're doing while we're doing it, rather than at the end of the research process. So thank you.
Thank you, Dr. Salisbury. Yes. Oh, yes. For in person, we can acquire. Yeah. Let's take a look here. Now, several comments had come in. I saw this question that had just come in here. I could always, oh, thank you. Thank you, Jürgen. So how about I pose a question while I read through these and try to synthesize this. One thing that struck me, and maybe others have questions too, I think as a clinician, it's often hard in a clinical encounter to say, I'm going to address a social determinant of health. It's hard to turn that into a clinical decision. And I think you've demonstrated this process of identifying, you didn't call it that, but I mean, do you consider it that way? You're identifying social determinants of depression or other mental health conditions in the peripartum period and finding interventions that address those.
Yeah.
Is that the way that you see it?
Yeah, so I think we made a conscious effort not to ask or not to use the term mental health, and just to ask girls. So the kind of wider question we're asking is, what are the challenges and the opportunities or the supports that you've experienced during pregnancy and the year after birth? And so these things often then come out with not mental health specific issues, but things that we know are related to mental health. And I think part of the reason why was because we wanted to be able to have something that was tangible and have tangible things that we're addressing, because that's what we need to do in order to have these girls and these families and communities actually engage and want to take part. But we can pull into that what we know from the evidence about what works to support mental health, and tie that into what we're doing. So I think oftentimes, sometimes people think, oh, well, you're just going to come up with something that doesn't have any mental health. You know, there's nothing mental health about it. And partially, I kind of like for the girls to think that, you know, not see this as a mental health intervention or think, you know, that's what we're addressing. But we are using the evidence base and bringing that in because we are the stakeholders as well. So our ideas and what we know from the evidence comes into that and helps to pull together, you know, what it is that will help these girls in addition to those tangible things around, you know, maybe it's health literacy or issues around poverty reduction, or returning to education. And these are just some of the things that have been coming up from the discussions that we've been having with stakeholders about the things that are most important to them.
Yeah, thank you. And I'd like to encourage any participants to write in additional questions or comments. Wonder if there's any yeah.
Sure. Thanks, Tatiana. It's really interesting and, you know, near and dear to my heart, all of these approaches. I'm curious, you know, that there is, I'm hearing in your presentation this idea of getting outside of the box of, you know, kind of traditional treatment models, Western treatment models for mental illness, mental health. You know, this is something that could be diagnosed using a certain framework of diagnostic approaches. And I'm just curious that there, you know, so far my work has really focused on, you know, how do we get we have these evidence-based psychosocial interventions or treatments, but they're not being used. Like, how do we get them into use? But like, to what extent does that fit in your model, or is it really thinking much more broadly?
Yeah. So I think that the focus of this is around promotion and prevention rather than around treatment. Although there is a screening, you know, there will be a screening aspect to this so that we can signpost and enter, you know, put people into a care pathway if they need it. With human-centered design, it's not necessarily that you have to say we're starting from scratch and go from there. You can start with an intervention and say, we think that this will work, but there's, you know, how is it that we adapt this or make it relevant to this culture or context? And so you can go through that route with that. And that's partially, you know, even though we're not talking about treatment, when I'm talking about bringing in the evidence base, it is things like, you know, problem solving skill, like bolstering problem solving skills, or helping to increase the positive relationships that girls have. And these sorts of things that are already, there are existing interventions for these things and these issues. And by no means do we want to reinvent something. I think that's a waste of everybody's time. So we can start with those and say, okay, you know, we're looking at problem solving. So what are all the problem solving interventions or interventions that include a component of problem solving? What do they look like? And do any of these things seem like they match that culture and that context? And then we can say, okay, well, maybe that one does. Now, how do we adapt it and think about it? So I think that there's kind of room both ways. So you want to see, what do you have in your arsenal already that you can use and adapt in a way that is helpful. But then there's this additional process of identifying the gaps. So what is it that we don't have an intervention for, which, people are saying that they need or they want, and then can we work to try to develop something like that to add on and complement what's already there?
Thank you. Yes,
I have a question.
Dr. Collins.
Thank you for that, Cost. That's great. So I love your image of the ball of thread and the different viewpoints coming together. And I also like that you talked about yourself as actually an integral part of this as a stakeholder with everyone else. So you're not kind of watching and watching the stakeholders over there. So can you talk about what consensus actually means in that context? And are there viewpoints that take priority? Do you think about the adolescents and their viewpoints, or what about the principals and teachers and parents and everyone else? How do you think about that?
Yeah, so I think this is the hardest part. So I say, when you're talking about this, and when I tell other people, well, this is what we're doing, we're bringing people together, everyone says, oh, well, yeah, that seems like a no-brainer. Like, why does it take so long and why isn't it happening? It's not happening because it is ridiculously difficult. It is really hard to manage, all of these stakeholders, and also kind of the underlying and kind of long-standing tensions between some of these stakeholder groups and the hierarchies. And so what we've found is one is this process of kind of asking everyone first, what are your viewpoints? That allows us as a research team to really start to synthesize, well, what are the main things that are coming out? And are there things from each of these stakeholders that we can pull in? Because there has to be something for each stakeholder that they can say, okay, at least I've got this little bit. So there's compromise. No one's going to get it exactly the way that they want, but at least they can see something of what they want in the finished product. And that helps, I think, to kind of clear and focus the mind that this is what it is that we're going to do. And we do that also by identifying a particular problem, because it's so, everybody has their kind of pet issues and things that they think will happen. But if we can really try to align that so it's something very simple that we're trying to address, then we're more likely to kind of, have everybody coming together. Now, this whole idea of how do you make a decision, it is, what we do is we do a bit of voting. So we try to make things as visual as possible within our workshops. So when they were ideating, coming up with all of these ideas, there were things that they put up on the walls, bits of paper or with either pictures or written words that would identify what this idea was. And then each person is given, 3 dots, and they go around and they just put their dots on the things that they like. And then we look and see what's coming out and what is most important. So it's not always, I guess some people might say, oh, well, not all the things that I wanted were the ones that came out. But I hope in doing that and helping people to see that this is a kind of a democratic thing that we're doing, that helps them to realize, okay, this is important to the group. And so we can think about it that way. The other thing about this weighting of, and I think, when we're doing this equity-based design, so equity isn't equal. We don't all have the same value and weighting of our opinion. First and foremost, we really want to focus on these girls because, so often in everything else in their lives, they are not the focus and everything's done to them rather than with them. And so what we've ended up having to do so that we don't lose them, because there is a worry, if you bring all of these stakeholders together, the hierarchies will form and these girls' voices will just go. So although the girls are there in the wider stakeholder meetings, when we do small group discussions, everybody's mixed up except for those girls who stay together, and they have a facilitator that helps them and will be able to kind of vocalize their ideas if there isn't someone in the group that wants to do that. So we try to do that, and we try to keep that first and foremost. But I think it depends on where you are in the stages. If you're thinking about the delivery of an intervention, and we've already decided who the partner is going to be, then they kind of have a little bit more weight about how it's going to be done, because we want them to feel like they have ownership and that they've been able to kind of adjust it to what will work for them. So it is this kind of balance and shifting of power as we go along. But I think the key thing here is that although we do, I do from, London, have power, and I do have power as a PI, I really try to instill on our site teams that actually this is their project, and it doesn't work if they don't think that it's theirs and take control, and they don't also then try to promote that and support that within the communities.
Great. Thanks.
Yeah, a couple of questions came in about maybe reconsidering a figure, use of maybe a Venn diagram, or whether there's been really about methods, about how are you gathering data, how are you collecting the data? I think it's an interesting question as well. How would one report on this study, for example?
Yeah, it's a bit tricky because human-centered design is kind of quick and we don't have time for, going through, thematic analysis and all the coding and the transcripts and all of these things. So we kind of are doing it on 2 tracks. So as we're moving along with the study, we've got kind of our design team and our field researchers who are working with notes primarily. So at the end of each session, they have a series, they have a workbook that they have to fill out that talks about what they've learned from this activity, how is it different to the information that they've already received, as well as what are the things that are coming up time and time again so that we can try to help and develop consensus. Those activities are then they're recorded and they're, the transcripts are made and they're translated into English if they're conducted in a different language. And the research teams also at a later time when kind of there's downtime in the data collection process are coding those interviews. So we finished, although we're now in the kind of ideate phase where everyone's brainstorming ideas and beginning to prototype, we've just finished coding all of those interviews from the very beginning of the project. So we can start to then see, are there things that we missed? And it's quite nice because we can still bring those ideas in at this point in time to kind of further refine or think about or question, include a line of questioning within the workshops that are going to be happening in the future. So we've got those kind of 2 things that are happening. And we're also trying to collect data on the whole process. So we are interviewing our field team and asking them about their experience of using human-centered design, because this is all very new for them. So some of them are qualitative researchers with kind of a long-standing history in that, but others are just, they are community members who are just working usually in data collection for different studies. So they have some experience, but not a lot. So we are asking them about the feasibility, the acceptability, the appropriateness of this approach within their context. And also, what was the training like? And did they feel competent and confident to deliver these activities based on the training that they were given? So there are these kind of multiple strands that are coming through. We're kind of going, as we go, we're learning different things and thinking about other ways in which we kind of collate and also share our learnings. So it's interesting, but it's not at all fixed.
Okay, thank you. Yes, yeah.
Oh,
Yeah.
No.
Yeah.
So Tatiana, when we spoke yesterday, one of the things that I was struck by was you commented that someone you had pitched this work to had commented that this seemed pretty risky, and risky means like, what will be, it might not come to much, right? Which I think is a really interesting point. And it comes to mind a study now 20 years old that used similar kinds of work. It was with adolescents in Philadelphia to see what were the obstacles to trust with their primary care provider. And they did what's called a nominal group technique, to very similar in some ways of gathering consensus information and prioritizing, and it was very systematic of things. And at the end, the result was, and this was published in the Journal of the American Medical Association, that there was a big concern that the providers weren't washing their hands. And there like 2 sides of that. It's like, well, gosh, it's kind of trivial, right? But it was also very interesting you know, that was the kind of thing that was really undermining their concern, their trust in their providers. And that was the first time I'd heard anything about that. And I thought it was really interesting. And on the other hand, I mean, there are interventions now about, you know, we've come a long way in getting providers to wash their hands. I haven't really studied to see whether it actually improved trust, you know, with the adolescents. So that would be worth following up. But I bring it up because there is a worry, right? Like one of the uses of human-centered design is you have a product and you're coming from the commercial end, right? And you're trying to get it sold, you know, you're trying to get it. And so you have this very concrete thing that you're trying to get input on with the goal of having as many people buy it as possible. And that's your measure of outcome. And, you know, you're marrying this, it seems like, to community-based participatory research kinds of ideas of let the community guide you, which is awesome, but might take you to, we need to get our hands washed, which, you know, would be, if that turns out to be how you get people to feel better about their connection with their provider, great. But I'm just sort of curious about your thoughts. Are you concerned or worried or getting headwinds about you know, doing this work because of the risk, you know, that it entails?
Yeah, so I think when we talked about that risk, you know, in that discussion that I had with someone very early on, that was 2017, 2018. It was before kind of human-centered design really came into people's consciousness within the field of mental health or global mental health. And so there was just a lot of kind of question about it because it's different and new. And I think, you know, we're not the best at new and different methods, especially for funding, for getting funding. So, you know, there is a part of the thing that I have learned along the way of doing this. Now, this is the second project that I'm using these techniques within, is to be able to let go and not be so set on this is what it's going to be. You know, of course I have an inkling about what's going to come out. I think you can't not have that when you're hearing things and in meetings and learning what's going on within the sites. But there is, you know, there is a chance that it might all just come up with nothing that is all that useful. But I think that's kind of the nature of research in general, is that there's this possibility for failure, and oftentimes it's mostly failure. But there is this kind of glimmer of hope, I think, that number one, we come out with something that does work, but two, the fact that it has been designed, you know, with all of these stakeholders, potentially has that implementation aspect, which is, you know, that's the key thing that we're really missing. Is we've got these interventions, but what is it about the implementation, and how do you implement and think about that? That are the key things. So I think in addition to the intervention itself that comes up, it is this process that we're learning, and what are the things that we're learning to refine? Because, you know, it could be 5 years from now, we might say, oh, that human-centered design idea, that was a really dumb thing. Why did we all, you know, spend our time doing that? And it could be something else. But I think as long as we're open to that, you know, flexibility, that it isn't necessarily the be all end all, but we're on the right track, that it's a good idea that all of these stakeholders should be engaged and involved and see an importance in an intervention for it to be successful, is key.
So I have a question. Maybe this is, I don't know, maybe it's too philosophical, but let me try it. So you're in London and you're doing this work in Mozambique and in Kenya. What makes you think that a person who is in London can help people in a setting like that think of things that they wouldn't have thought about themselves?
Yeah. So I don't think I think this is a thing about global mental health in general. And I just actually had a conversation with my PhD. Yeah, I had my PhD student, one of them last week, had a breakdown, and she thought she had to do her upgrade presentation, and she got some feedback from people, and she said, am I the right person to do this? Should I not, you know, I don't think who am I to say that I can do these sorts of things? So I think one thing is it's really good, it's reassuring. You know, I have this recurring question of myself about who am I? You know, I was born in California, grew up there, moved to London. My experience of life is very different to many of the people that I'm working with. But if I can keep that in mind And the thing is that I'm actually working, it's not that I'm doing these things. I've got kind of this framework and this idea of how it works, but it's my collaborators and my colleagues that are doing these things. So as long as it's owned by them and they understand and they see that that's important, and these are things that we've talked about, before we put in this application, we talked about, well, do you see this as an issue in your community or in the communities that you want to work? Here's like something that we're looking at as a method or approach to addressing this problem. What does this seem like to you? So it isn't just us coming and saying, okay, you're going to do this and you're going to come up with these different ideas. And the thing is that in human-centered design, they're coming up with the ideas. We're not feeding them of these are the ideas that you should be having. And oftentimes the things that are coming up are things that are happening in their community that aren't attached to perinatal mental health for these girls, but are other things that they think, oh, but this is happening. And we do give them examples and ideas just so that they can understand, because it is hard. I think that was one of the things that we found, that it was hard for people to think outside or think about things that they don't necessarily see as related. And so helping them to do that. But I think, that's something that we do here, in the States or in London as well.
So what are you, I guess my question is, what are you bringing to them? What are you helping them do that they couldn't do on their own? Is it that you're raising funds and then using those funds and giving them the permission and the time and the resources to think out of the box, stuff that they might not do by themselves otherwise? Mm-hmm. Say a little bit more about that. What is it that you actually bring as a global health researcher to this group of human beings who have their own history and context and probably tried lots of things to try to make it a better experience to be a pregnant adolescent, right? I mean, it's not like we've never ever thought about that, right?
Yeah.
But what is it that we bring, that you bring?
Well, I think you've nailed the head on one of the primary things, is we do bring the money. Right. And that's where a lot of the times the money has to be funneled through a high income country and the partnerships there. So that's one issue. And I think that we're moving a bit more towards trying to have equity in that situation. But for me, I think it's this understanding of these methods and the training and the capacity building that we bring to help help so that our partners in these communities can actually begin to do these things on their own. So when we're doing the human-centered design work, we're training the teams, but we're also training the communities about how this all works so that they understand. Because part of the issue is that if we leave at the end of a research project and they don't know how these things work or this process, then they don't have the skills and the ability to kind of keep it running without us. So then it ends up just dying out. So I think that's, those are kind of two of the things. And I would hope that my expertise is of use to people. And as long as I'm not saying this is the way you have to do it, but these are some ways that you can do it and we can talk about that and work together, then I think that's one of the kind of beauties around this. As I mentioned, those strands of these different perspectives kind of coming together to address that. But I think we also, working in global health, you have to keep in mind that, first and foremost, it is about the experience and that weight of what is going on the ground and what people know in their own backyard.
So you might end up believing two things at the end of a project like this. You might end up really having generated a new idea that nobody had thought about before, right? And you might also not generate a brilliant new idea, but you might have generated a group of people who have learned some skills and processes and feel empowered to do things that they haven't done before.
Yeah, without me.
Right.
Exactly.
It's a really interesting question, right? And certainly a question that people are debating, at least people in the North are debating in global health. But I actually think that research, anytime people introduce research, whether you're here, whether you're actually introduced to people that are not other researchers, right? You're usually introducing a new way of framing things, right? You're introducing a new way of asking questions. And that can often be useful wherever you are. I mean, I just got off of a conversation with an Ethiopian researcher working in the United States in Flint, Michigan, right? Who's talking about brings brings her perspectives as someone trained, raised in Ethiopia, but addressing health disparities in the United States and actually recognizing that her perspectives actually have a particular value in this context. So I think it goes both ways. I actually think that's what research offers, is a chance to think creatively and systematically in ways that often non-researchers don't tend to do automatically, right?
Well, we're just about at 1 o'clock. Thank you to Dr. Salisbury today for presenting. Thank you for the group here on site, Dr. Collins, Dr. Inser, Dr. Bennett, for this sort of hybrid, and for the participants here on the webinar. And we'll end grand rounds there for today. So thank you.
Thanks very much.